This presentation today is tracing movement from thought to action. And this is adapted from work by myself, Robert Schreier, as well as Dr. Emilio Paradorn. And in essence, our goal here is to trace movement through the brain and the central nervous system, down through the brainstem, cerebellum, into the spinal cord, and into the periphery, into the peripheral nervous system. As we go through each region of the brain, we'll be identifying what each region is, how it impacts movement, and if there were damage to that area, what symptoms we might expect to see. So to begin, looking at a closed loop movement system, which is essentially a movement that is initiating from an internal thought or internal process, as opposed to an open loop where it's initiating from afferent. Both are occurring on a regular basis, but the afferent will simply add the initial afferent information that triggers the requirement for a movement. Once that triggers, the rest of the pathway is very similar, if not the exact same, to a direct loop. So no matter what, movement is impacted, and for our purposes today, starts in this region right here. So the limbic system, as we dive deeper into it, is essentially the center for our behavioral function, emotional function, and motivational function. So behavior, it is how we act and react to our environment. Emotion, it's a physiological state associated with our feelings, our thoughts, and our behaviors. And motivation is determined our engagement in that behavior. Now, it's important to note that this is a neuronal circuitry, not necessarily one specific region, rather a circuitry. Now, that circuitry is comprised of multiple different regions in the brain. The hypothalamus, which is really our standard control center for breathing, blood pressure, pulse, hunger, thirst, pain, and pleasure. Our amygdala, which really controls our emotions. If somebody were to present with a deficit in their amygdala, they would have emotional lability. They would have, in essence, the fight between sympathetic and parasympathetic nervous system, the fight or flight type of reactions. We also have the olfactory bulb, which is in control of our sense of smell. And if you have a deficit here, obviously you would have impaired smell. Now, the main area here for us in the world of movement is the hippocampus. And the hippocampus is required to transition short-term memories into long-term memory. But also, it's associated with spatial orientation, and if you have a lesion, naturally disorientation. The hippocampus has been cited in numerous articles as it relates to motor learning, and this is something that we can certainly explore much deeper in future endeavors. Now, as far as the limbic system goes, it's not necessarily an area that we're going to look at from a standpoint of treating as a physical therapist or an occupational therapist. This is a region where we're going to look at the limbic system in how it impacts movement and how it will impact our motor planning, our motor learning, and our interventions for our patients. But we're not necessarily going to be focused on correcting the limbic system for the most part. Now, the next region here, as we've moved already on the slide, is the prefrontal region. So the prefrontal region, this is the region that orchestrates our thoughts and actions in accordance with our internal goals. The best summary of this is executive function. So this is distinguishing between good versus bad or better versus best. Now, this is defined very well from a thought perspective, but it can also be associated very closely with movement perspective, determining the better versus best type of movement for the task at hand, or the good versus bad movement. Also, the prefrontal lobe is responsible for working towards a defined goal, prediction of your outcomes, and again, expectations based on actions. So if you were to have a lesion in your prefrontal lobe, you would notice significant cognitive disorganization, inability to have a clear plan, both from a cognitive standpoint, but also from a movement standpoint. So ultimately, prefrontal lesions will demonstrate disorganization in motor planning. From the standpoint of that prefrontal region, unlike the limbic system, this is something that is directly required for movement, is directly engaged and directly triggered during movement, and most importantly, during movement which requires you to have a plan or to change a plan. So non-stereotype movements are going to be relying heavily on the prefrontal lobe. So this is something as a physical or occupational therapist or anybody in rehab medicine we can key in on and try to improve or correct. Next, we get into where the movement really starts to occur, the premotor cortex and the primary motor cortex. The premotor cortex, as you can see in this picture here, is divided into medial and lateral premotor cortex. Now, this area is not necessarily a distinct specific region, rather it's a complex mosaic of interconnected areas. It does happen to be along the frontal lobe, but it's along the posterior border of the frontal lobe as the frontal lobe merges with the primary motor cortex. So the premotor cortex itself mediates the selection of movements. The lateral premotor cortex is in response to external cues, anything that's coming from outside of the body, whether it's auditory or visual. However, the medial premotor cortex is in response to internal cues. The medial premotor cortex is also called the supplemental motor area, and as you can imagine, this area will be able to supplement for the primary motor cortex when in need. So if we were to have a lesion to this area, we would notice a reduction in the number of self-initiated or spontaneous movements. Notably, that is more specific to the medial premotor cortex as it is focused on internal rather than external cues. For the lateral premotor cortex, if you had damage only to this area, you would still have that self-initiated or internal cueing. However, you would struggle with external cues for movement. So, as we're now starting to transition, I think we have to take a little bit of a deeper look. We have the limbic system and the prefrontal lobe, which is impacting our movement or our thought by emotion, memory, and motivation. But now as we shift into the movement, we start to have much more detailed, complex interactions. These interactions are between the cerebral cortex, which is the region that the primary motor cortex is located, the basal ganglia, and the cerebellum. So to take a little bit of a closer look, we can take a look at this diagram here, which demonstrates goal-directed control versus stimulus-response habitual control. But for our purposes right now, we're looking at the loops as a whole, not necessarily directed versus stimulus response. And what you note is that the movement is reliant on sensory input, but this sensory input is processed in multiple different regions. It's processed in the frontal cortex as well as the sensory motor cortex. That sensory input feeds into the primary motor output centers and ultimately comes in alignment with a loop of information that is being modulated through the basal ganglia. It's important to note that this information then transmits down through the cerebellum via efferent connections, but also through the brainstem and ultimately down into the spinal cord. But to get a little bit deeper into that, the primary motor cortex is impacted directly by the thalamus. It's not necessary for the basal ganglia itself, substantia nigra, globus pallidus, any of these areas, it's not necessary for them to interact with the primary motor cortex because they stimulate the thalamus. They either excite it or inhibit it. Now the thalamus, based on its level of excitation or inhibition, will then have impact on the primary motor cortex. So how does the thalamus get its input? Well, it gets input from two distinct areas. One, the basal ganglia, which we've spoken about, but the second part here is the cerebellum. So the cerebellar afferents actually send signals to the ventral lateral nucleus, the thalamus, which ultimately excites or inhibits. At the same time, the basal ganglia afferents are sending signals to the ventral anterior nucleus. So in essence, all movement is going to be modulated, initiated, modulated, and controlled through the thalamus. Once that information passes into the thalamus, it's then going to have to go down through efferent channels into the muscle. Now this diagram here shows in the top region here the motor cortex with its multiple different rays, and that information tracks down into the corticospinal tract. And we can see that corticospinal tract coming down through the parietal lobe into the temporal lobe, through the central mass of the brain, and we note that there's a loop in this region where it's interacting with the thalamus as well as the basal ganglia itself, and also passing down into the brainstem. Now what this picture does not show is the efferent information coming off of the cortex into the cerebellum, but what it does show is as the information from the corticospinal tract moves down through the basal ganglia and into the brainstem, it crosses over midline, so therefore left brain will affect right body, and in doing so it is receiving afferent input or cerebellar efferent output into the mix. And essentially what this means is now as that corticospinal tract carries information down to the muscles to perform an activity, the cerebellum is sending its own information over to that same exact region to provide feedback and to ensure that we have co-contraction across midline as well as stabilized movement. But in addition, we notice this other tract here, which is the spinocerebellar tract. This tract sends it right down the spinal cord and actually carries information down to the muscles themselves, and it actually operates at a faster rate than the corticospinal tract, so it can ultimately have more impact, or it can have impact on the movement before it even occurs. The other area here, obviously we have to look at, is the afferents. So this is the information that is coming in to the brain. This tract here is the corticospinal fibers carrying some afferents back up into the brain. And we have the motor cranial nerve nuclei, as well as the corticonuclear fibers, all within the brainstem. And this region here is essentially how the brainstem can control posture and stabilization in our body. So the motor cortex. Motor cortex is responsible for directional movements of body parts, but not specific muscle action. The motor cortex is essentially responding to what it's being told by the thalamus and what it's being told by the premotor cortex, as well as the frontal cortex. So it's not deciding what muscle to engage. It is receiving information and then directly sending out the information to whatever muscle it was told to engage. So these signals travel directly to the lower motor neurons, the lower circuit neurons, and obviously that's going to happen through the brainstem and the spinal cord. Along its way, as this information is heading down, it has to pass through and be impacted by both the basal ganglia and the cerebellum. It's important to note that the motor cortex is directly associated with the somatosensory homunculus, but it's not in direct alignment. What this means is it's essentially next to the somatosensory region, and we're all familiar with the pictures of how the homunculus, which shows us which regions on the surface of the brain are controlled by that area, being hand or mouth or foot. And the motor cortex kind of parallels that, but it's not exact. In fact, the motor cortex is more diffuse and more spread out throughout the region. Now, this is an artistic rendition of the brain activity related to the primary motor cortex. And while it's not necessarily 100% accurate, what's important to note is that we see multiple different colors here for different regions of the body. Most notably, we see the wrist, which is in dark blue, and we see that dispersed throughout a very large region within the brain. What this means to me is that if somebody were to have a deficit or a stroke, say in the primary motor cortex along the fissure from the frontal to parietal lobes, they might damage the area that normally controls the wrist. However, we note from this picture there's multiple other areas throughout the region that can control wrist. And this is one simple explanation of how we can utilize neuroplasticity to essentially have neighboring areas, or sometimes not even neighboring areas, but underused areas, take over for a region that has been damaged. So how does all this information get down to the muscle? Well, this all occurs through the brainstem and the spinal cord, and it occurs through our tracts as they pass through the spinal cord. Without going into detail on these tracks right now, it is important to be able to note the pathway as well as the function for these tracks. Most notably the corticospinal tract, which goes right from the motor cortex to the lower motor neurons, and is essentially in control of fine voluntary motor for the limbs, voluntary body posture, and adjustments of that voluntary body posture. Let's return back to our Prezi here. Now, one very interesting component here is that corticospinal tract, which remember is the center that's involved in transmitting information from the primary motor cortex down to the muscle, down to the movement area. This corticospinal tract actually only derives 30% of its input from the primary motor cortex, with another 30% from the premotor cortex, and most notably 40% from the parietal lobe, or the sensory region. This essentially makes it very clear how important afferent information is in ensuring normalized movement. And also, this is notable in an individual that has a lesion that affects primary motor cortex or premotor cortex. And even if they're only operating at 10% of their norm, they will have the ability to perform activities if they're given enough sensory input and enough activation through the parietal lobe. So now this information is sent out. It's sent out through the corticospinal tract, and as it's being sent out, the relay of information is being shared from the basal ganglia. So the basal ganglia itself is actually a complex system with multiple different regions. You have your globus pallidus, your putamen, your substantia nigra, your subthalamic nucleus, and your thalamus. Now, the initiation of motor activity and modulation of cortical output is all happening directly through the thalamus. And the way the thalamus is being excited or inhibited is coming through neurotransmitters that are released by these structures within the basal ganglia. When you take a little bit of a closer look, you see that there's quite a sophisticated infrastructure communicating between substantia nigra, putamen, globus pallidus, as well as the thalamus itself. And that interconnected communication either excites the thalamus or inhibits the thalamus, ultimately exciting or inhibiting the cerebral cortex. So what would occur if we were to have damage to this region? Well, noting that the basal ganglia decides how much inhibition to give to motor cortex, we would note that over-inhibition would actually cause Parkinsonism. This would be decreased limb mobility and increased trunk stability. On the flip of that, the under-inhibition would actually cause excessive movement or dyskinesias. This is where you would have decreased trunk stability and increased limb mobility. And this would result in tremor, chorea, athetosis, or hemiballismus, often symptoms noted in Huntington's chorea. So as that information has been modulated in this brainstem, we know the next region to be modulating that information is the cerebellum. The cerebellum itself can be broken up into three distinct parts, or lobes: the anterior, posterior, and flocculonodular. Now, over the years, there's been many names assigned to these different regions, but the most applicable name for rehab medicine are the functional names. The spinocerebellum is the anterior lobe, And the spinocerebellum itself is responsible for information between the cerebellum and the spine, ultimately controlling for muscle tone and posture, as well as stereotyped activities. So these are the activities that don't necessarily require the cerebral cortex's intervention. They can receive that information, any afferent information, and with input from the cerebellum into the brainstem, you can actually perform your stereotyped activities with very little request or information needed from the cerebral cortex. However, the posterior lobe, which is better known as the cerebrocerebellum, it's what's carrying information from that cerebral cortex to and from the cerebellum. Now, this is going to have a major role in non-stereotyped activities. These non-stereotyped activities are obviously requiring information from the cerebral cortex. That cerebral cortex naturally is going to be requiring information from premotor area as well as the prefrontal cortex in order to define that non-stereotyped activity. And the last region is the flocculonodular, which is better known as the vestibulocerebellum, which carries information to and from the vestibular system to the cerebellum, ultimately having a major role in head and eye movement, coordination, balance, and posture. This information can be deduced through our tests and measures during our normal physical therapy examination. When we perform our examination, if we were to see somebody that had difficulty with coordination, we could ask them to perform a stereotyped activity and assess their coordination. If that's uninvolved or not affected, then we might note that spinocerebellum could be uninvolved or intact. However, if non-stereotyped activities are not affected, but stereotyped activities are, we can make the assumption that the cerebrocerebellum is not affected and the spinocerebellum is affected. So, to take a more broad look at the cerebellum, it's essentially the coordinator of movement. It does this through time, speed, direction, and precision. A common way of looking at the cerebellum is to look at it as a regulator, a comparator, a planner, and a learner. And as we dive a little bit deeper into that, we start with the regulator. In regulating the movements, it receives afferent projections from spinal cord, as well as the cortex and subcortical brain regions. It also receives input from the motor and non-motor areas, as well as sensory, somatosensory, vestibular, auditory, and visual. So essentially, the cerebellum is receiving information from every major player in movement from a central nervous system standpoint. Interestingly enough, the cerebellum is outnumbered in afferent over efferent by 40 to 1. Again, the cerebellum is receiving 40 afferent projections to every 1 efferent. So its vast afferent information is bringing back all that information that is then going to be turned out into efferent information. This efferent information is carried both up to the cortex as well as down to the brain stem with the midbrain as well and into the spinal cord. But it doesn't stop there. The cerebellum is not only a regulator, but it's also a comparator. And this occurs in the spinocerebellum. And this is where you actually have a comparison of the actual movements as depicted by the peripheral sensory feedback information with the movements intended by the motor system. If the two don't compare favorably, then instantaneous subconscious corrective signals are transmitted back into the motor system to increase or decrease the levels of activation of specific muscles. So what this is saying here, that the spinocerebellum is in real time comparing your actual movement with what you intended to occur and utilizing its afferents to determine if the exact intention is being carried out. Many factors or variables would impact this, whether it's colder or warmer, or the platform that you're stepping onto is moving or not moving. Now, this information has to happen very quickly. In order for the cerebellum to receive afferent information, process it, modify it, and send information back is quite a difficult task. However, the cerebellum, we know, has its own ability to send out efferents that are significantly faster than the premotor cortexes. And it also, over time, is able to create what's called a predictive compensatory modification. So this not only is its ability to modify, but it's also able to predict what's about to occur based on various factors, then modify the movement to ensure success. So it does this through comparing motor performance occurring peripherally with motor signals from the cerebral cortex. Ultimately, this becomes an excellent source of compensation for errors in our movement. The better we are at compensating for these errors in our movement, the smoother our movement will be. So ultimately, the cerebellum as a comparator is operating in the spinocerebellum, but it's important to note that it's receiving input from everywhere throughout the CNS as well as input from the periphery. Now I move on to the next level. It's also a planner. And as a planner, it doesn't do this independently. It does not operate without the cerebral cortex. Rather, it plans as an assistant. It's an assistant for the cerebral cortex. But what it does is it gives the cerebral cortex the ability to plan the next sequential movement. And it can do this a mere fraction of a second in advance. So while your current movement is being executed, your cerebellum is feeding information to and from your cerebral cortex to modify that movement so that the next movement will be smooth and precise. Lastly, the cerebellum is a learner, and it essentially learns by its mistakes. So if a movement does not occur exactly as it's intended, the cerebellar circuit learns to make a stronger or a weaker movement next time this movement occurs. And essentially, this plays forward to the need for error correction. And in any neurological condition, when you're recovering, it is important that errors are actually allowed to be made. And when they are made, the individual is allowed to try to recover from that error. Okay? Now, how does this occur? Well, it occurs really from a neuronal standpoint. These changes occur in the excitability of the appropriate cerebellar neurons, ultimately giving the muscle contractions a better correspondence with the intended movement. So what does all this mean in the real world? What all this means is that the cerebellum is deeply involved in motor learning and deeply involved in our adaptive feed-forward control system. Essentially, programs or models are voluntary movement skills based on a memory of previous sensory input and motor output. With regard to motor learning, when the cerebellum is damaged, our learned motor programs cannot be used. We're then forced to rely on our sensory feedback loops, which occurs throughout the cerebral cortex. This is significantly slower and does not have real-time adaptations. So somebody that lacks cerebellar input is not going to be able to react, it's not going to be able to learn, and ultimately it's not going to be able to regulate their movements, ultimately leaving an individual with a slower, more cautious movement, which presents itself in the form of an ataxia. Now, the cerebellum can also be divided into medial and lateral. So you have intermediate, which would be medial, and lateral, which would be lateral. Now, the lobes that we previously discussed, the anterior, posterior, and flocculonodular, those lobes are occurring anterior to posterior. If we were to take a sagittal cross-section through the cerebellum, that mid-sagittal region would be the intermediate region, and that's going to include regions from the cerebrocerebellum, the spinocerebellum, and also the flocculonodular or the vestibulocerebellum. Lateral will also have those same areas interconnected. However, when looking at it from this perspective, we can note that the intermediate region will actually have an impact on stance and gait, control of posture. Sitting, you'll note that an individual will lean toward their affected side if they were to have a cerebellar dysfunction. They would actually deviate. Their head will actually deviate towards the side of a lesion. and that's your head tilting toward that affected side. You'll also note ocular motor dysfunction with a midline or intermediate cerebellar dysfunction. A lateral dysfunction would present itself with hypotonia, dysarthria, much more significant ataxia, including dysmetria and dysdiadochokinesias, as well as your intention tremor, your impaired check or your rebound phenomenon, and some overlap with your oculomotor dysfunction. So we've now moved from thought and impacts of emotion and behavior and motivation into planning in the prefrontal cortex and executive motor planning or cognitive organization, into the premotor cortex, where we're going to have that information being impacted by internal and external cues, as well as the organization of that movement. That movement then passes into our primary motor cortex, which is going to have interaction with the basal ganglia as well as the cerebellum. As this information is passed through those regions, the basal ganglia has a direct impact on the thalamus, impacting the primary motor cortex, while the cerebellum itself also impacts the thalamus, which impacts the primary motor cortex. It additionally sends its own signals down through the brainstem into the spinal cord, affecting that movement. So we pass down into the brainstem, which is made up of four major regions. There's our reticular formation, which is responsible for the transmission of information related to motor control or balance, our respiratory functioning, and our consciousness. We also have our long ascending and descending tracts, which is where information is relayed from the cortex through the brainstem into the spinal cord. We also have our centers for our cranial nerves and the cerebellar nuclei that are interacting directly with the cerebellum. So in essence, our reticular formation is that formation of overlapping information in the brainstem itself, which will contribute to motor control. Our long ascending and descending tracts would include the corticospinal tract, which is carrying information from the cortex down to the limb. Our cranial nerves are interacting right there at that brainstem level, and our cerebellar nuclei is where the exchange of information coming out of the cerebellum or into the cerebellum is taking place with the long ascending and descending tracts of the brain and spinal cord. So if we had symptoms or damage in the brainstem, we would see potential of respiratory distress, poor postural control. Naturally, anything related to the long ascending or descending tracts will be interrupted. And depending on how much interruption occurs, we'll either have an incomplete or a complete lesion, which is defined as damage within the brainstem, but not as clearly defined as damage within the spinal cord. However, we can make the correlation between complete lesions of spinal cord injury and complete lesions of brainstem, as well as the complete lesions, incomplete lesions. Also, you would note cranial nerve signs and symptoms. One of the best ways during diagnostic examination to determine what region of the brainstem is damaged is through your cranial nerve assessment. Ultimately, this will tell you what other areas might be affected. And naturally, depending on what is impacted, your cerebellar symptoms will persist as well. Now, the next portion of this is actually taken from Dr. Uparidorn's information, which is the information as we descend past the central nervous system. Naturally, we have the spinal cord to touch on, but then we go right out into the periphery. So to run through the spinal cord's role, it essentially carries our motor tracts for us. So it's corticospinal tract or the motor tract. 90% of that information, it's important to note, is contralateral, but 10% stays ipsilateral. Thus, if you have a brain infarct to the left part of the brain, you'll have a right hemiplegia or hemiparesis. But it is important to note that 10% of that stays on the same side. So you may have some minor symptoms on the left side with the majority of your symptoms on the right. And this is essentially a review of these tracts as they travel through the spinal cord, giving us the ideology or the knowledge that if one region of the spinal cord were affected, we would lose either sensory or motor afferents or efferents within the spinal cord, ultimately leading to a loss of that information being carried to the brain. So as we continue through, we can sum up our tracks in a much more simplistic manner by just looking at the specific areas that they control. So our corticospinal tract is actually not only one tract. It's broken up into a lateral and a ventral corticospinal tract. The lateral controls voluntary movement, especially in your distal limbs, while ventral controls voluntary movement in your axial musculature. Our rubrospinal tract will control voluntary movement in upper extremities, most detailed with precision control. Vestibulospinal, posture and balance, and the lateral and medial reticulospinal tract will ultimately control posture, balance, our spinal reflexes, both axial and proximal limb motions, and it will complement the actions driven by our corticospinal tract. Spinal cord injuries will present with various symptoms, obviously still upper motor neuron symptoms, and this is a basic example of an ASIA scale, which is used to determine whether an individual has a complete lesion in the spinal cord or an incomplete lesion in the spinal cord, thus dictating how we would perform our treatments. This picture here takes note of the different syndromes that can occur if a different region of the cord is impacted. Anterior cord will obviously impact motor, as our motor descending pathways are carried anteriorly. Posterior cord will impact our sensory, as this information is carried up through the posterior cord. Then our central cord syndromes, as well as Brown-Séquard, conus medullaris, and cauda equina syndrome. And these can be discussed in more detail in future discussions. So information is now complete within the central nervous system, and it must carry out to the periphery. In doing this, this occurs through the peripheral nerve. The peripheral nerve, if damaged, gives you lower motor neuron signs. So that's where you get your weakness or your loss of sensation. You have hypotonia, flaccidity, fasciculations, and marked atrophy. From here, the information is transmitted down to the muscles. Naturally, every limb requires the proximal bone of its joint to be stable in order for it to work optimally. So ultimately, we need our stabilizers to be triggered. So movement is not directed specifically to the muscle that will be moving. Rather, it's directed to that muscle as well as the stabilizers. And this is essentially known as our feed-forward system. The stabilizer turns on before the agonist. And a great example of this is your scapula, with upward rotators firing before the deltoid in order to perform abduction or flexion of the shoulder. Insufficient stabilizers will ultimately impact your ability to perform a muscle activity, which will essentially make you look weaker. It will make the muscle at hand look weaker. So in order to determine if it's a stabilizer that's causing the problem, you essentially need to manually stabilize the proximal bone, not allowing it to move at all, and reassess your strength measurement. If your strength increases, this is considered a positive, and this is saying that we do not have adequate stabilization in order for that muscle to work. Now at that point, that gives us the ability to differentiate between a weak muscle versus weak motor control. Now we would repeat the strength assessment, but cue the patient to turn on their stabilizers first. Not manually, rather we would tell the patient via visual, auditory, or tactile cueing. If the patient's able to cue in their stabilizers and then perform the activity at the same level of increased strength as your previous test, we note that it was poor motor control that was the problem, and that we have to reteach them to engage their stabilizers before activating the peripheral muscles. However, if they're unable to do that, we can surmise that it's weak stabilizers that is limiting their ability to perform the muscle activity. Now this information can be broken down in much more detail with Dr. Uparadorn's information, but this is a quick summary of this assessment. We assess our muscle strength. If it's found to be weak, we reassess while stabilizing the proximal bone. If there's no change, we note that this weakness is not due to weak stabilizers. However, if we have improved strength when we reassess while stabilizing the proximal bone, that tells us that there may be a stabilizer issue here. So the next step is to cue our patient to stabilize proximal activity. If they're stronger, that says that the patient has poor motor control or feed-forward system, and they have to work on that, or we have to work on that with them. If there is no change when you cue them to stabilize, this is going to be indicative of weak stabilizers. Now, in order for us to have this normalized movement, whether we have stability or not, we are going to require antagonist inhibition. In order to activate an agonist muscle, a biceps for example, to flex your biceps, you must have the antagonist of the biceps, which is the triceps, inhibited so that they're not firing at the same time. Now, this antagonist inhibition is controlled peripherally via your reflexive response at the spinal level to muscle spindle activity. And it's noted that this is hardwired in the spinal cord. But it's also controlled centrally via the feed-forward inhibition, which is initiated through the supraspinal levels. So antagonist inhibition could be due to a peripheral route or a central route. Either way, this information is extremely important, as if we don't have antagonist inhibition, we will not have normalized movement. So during our muscle assessment, we merely palpate the antagonist as we're asking an individual to perform an agonist activity. If we note that they have palpable activity in the antagonist, we're noting that something must be wrong in this feed-forward system or the hardwired peripheral system. Also, we're taking note of tone throughout passive range of motion. Now, one of the final ways to truly assess this is to try to fatigue the antagonist muscle and then reassess the agonist muscle. If we note an increase in strength of the agonist after the antagonist is fatigued, this is confirmation that the antagonist was impairing or inhibiting our movement. Finally, we have our atrophy of the agonist. So the agonist itself must have sufficient sarcomeres to generate force. And this is extremely important when you're considering endurance activities. So in order to assess for atrophy, observation will often show a notably larger or smaller limb. History of disuse will naturally feed into that decision. But also, a person with an atrophied muscle can and will respond to a traditional strengthening program, but they will not be able to increase their strength with cueing or stabilization. Ultimately, this opens up many more thoughts, and now we must consider how the central nervous system is involved versus the atrophied muscle and determine which dysfunction came first and which is significantly impacting this issue. So overall, we have traced our movement from the thought to the action. Throughout this entire process, we've spent much of our focus on the efferents, but it's important to note that afferent information is a must for continuous normalized movement. Now, this afferent information is taken in through the afferent tracts and ultimately impacts directly the premotor cortex in the supplemental motor area, as well as the cerebellum. We've discussed these tracts a bit earlier, but this is one of our tracts here. This essentially, again, we're dividing the spinal cord and understanding where these tracts lie. In blue, we have all of our ascending sensory afferent pathways. In red, we have our descending efferent motor pathways. And when we look at these ascending sensory tracts, we can divide them essentially into two major areas, the spinothalamic and dorsal column. Spinothalamic itself carries information for pain, temperature, and crude touch. The lateral spinothalamic, more specifically, is for pain and temperature, and the ventral spinothalamic is for light touch. When performing our examination, it will be important to differentiate between light touch versus pain and temperature, when trying to determine what region of the brain or spinal cord is impacted, and ultimately understanding which sensory tract is impacted. Lastly, of the ascending sensory tracts is the dorsal column, which is going to carry information related to proprioception, vibratory sense, deep touch, and two-point discrimination. All in all, this information is going to carry the afferent information back to our brain to ensure that our cerebellum, as well as our premotor cortex and our primary motor cortex, have all the information required to modulate the movement and to continue to perform the movement smoothly. This has been an overview of these systems. There's limited research going much deeper in each individual system and its impact on movement. And these areas are something that we will continue to explore in greater depth as we continue our studies in understanding movement from thought to action.